I'm just starting. Okay, so good evening, everybody, and welcome to the first of our online events from REMEDI Health, which we're really excited about. We have run face-to-face events before, and we will continue to do these during the course of the year, but we wanted to have a go with one of these online events as we can broaden our contact with people, but also it's much more convenient for yourselves to join in the comfort, I hope, of your home. So I imagine a number of you are very familiar with how to have Zoom. So we're going to be using the chat function for questions and comments. So if there's anything in particular you want to raise or log as a question as we go through, then just pop it in the chat. We are going to be recording this evening just so that we can let others who can't get here tonight see the event, and also if you want to see it again. So I'm delighted this evening to be to have with us Professor Mike Baxter. Mike is a friend of mine and we go back a number of years, but importantly, Mike is an absolute expert when it comes to hormones, endocrinology and diabetes, and amongst a number of things. So I just want to put together a little biog for you around Mike, who holds several roles at Ashford and St Peter's Hospital NHS Foundation Trust. He's a locum consultant in diabetes and endocrinology, the Chief Clinical Information Officer, not sure what that does, Mike, and a non-executive director at the Trust. He also holds an honorary professor of medicine at University of Swansea. Mike also runs a private practice in Surrey. Mike has achieved much in his career, including a significant number of publications and won awards. And importantly, Mike, I know, has a passion for diabetes, particularly optimizing glycemic control, blood pressure, lipids, and has an interest and passion in thyroid disease, autoimmune endocrine disease, pituitary disease, and weight issues. And I certainly know Mike as being fab at solving difficult diagnostic problems. Myself, my name is Deborah Evans. I'm a pharmacist, been a pharmacist for about 36 years now, and opened REMEDI Health about 15 months ago. And we're passionate here about helping people take control of their own health and offer a range of solutions, right from having a conversation about health and health issues through to diagnostics, treatment, and supply of medicines as a private pharmacy. So we're delighted to have you this evening. Thank you for joining us. And I'm going to kind of crack on in terms of the main topic for this evening, which is around testosterone deficiency. We're going to cover a range of different issues, but I think it's firstly important to outline why we chose this particular topic, particularly for our first online event. For us, it's important to engage everyone, whatever their gender, in their health. And we do see many women here with a specialism in menopause. We really help women going through what is a difficult change with their perimenopausal and menopausal symptoms. And it struck me many times as I listened to women that the symptoms that they're going through are also similar to those experienced by men when they raise health concerns. And there have been more than one occasion when I felt the male equivalent of HRT would be really helpful. But really tonight is about how we support men with their health. And it's not just about testosterone, it's about health generally, and being the best we can be as we enter our 5th, 6th and 7th decades and beyond. So I hope you'll learn much this evening, and please do raise lots of questions as we go through. So where does this all start? Well, when we engage with women around symptoms of the perimenopause and menopause, we know that estrogen deficiency causes a range of different symptoms, from cognitive issues such as brain fog, memory issues, depression, anxiety, just feeling that we've lost confidence, through to physiological symptoms like hot flushes, which many think of as the menopause, but are not present in everybody, through to tinnitus, tingling in the fingers, peripheral neuropathy, aches and pains in the joints. to the genital urinary syndrome of the menopause, where we may have incontinence, urinary symptoms, and vaginal dryness. But many symptoms that we listen to as women go through the menopause and estrogen declines are also experienced by men as they go through into their midlife from 40s, 50s, 60s and beyond. And as you can see on this slide, many symptoms, men experience are in common with women: weight gain, bone loss, night sweats, headaches, depression, lack of focus and cognitive function. So there are many similarities. So we're going to explore that tonight with our expert. And this just really represents what happens to us with our sex hormones as we age. For women, as our ovaries stop producing eggs and the hormonal control around all of that, our estrogen tends to drop off a bit of a cliff. And with men, the decline can be more subtle. And of course, many of us, myself included, as we go through those hormonal declines, we get used to feeling a particular way and put a lot of those symptoms down to just natural aging. And it's a tricky time of life. Often we're dealing with elderly parents and also adolescent and growing offspring, and sort of stuck in the middle with life and all of the pressures that throws at us. Often we ignore what might be happening to our bodies, and that some of the symptoms we're experiencing may be physiological. So just like estrogen in women, testosterone affects our whole body system, from our cognitive function, as we mentioned, in our brain, through to our muscles, our bones, our sex organs, which is where we typically think of testosterone acting, through to blood production and skin. So it has wide-reaching effects. And again, I'm going to let Mike expand on those. But when we think of testosterone deficiency or low testosterone, how many people does it affect? Well, only around 900,000 men in the UK are diagnosed with this as a deficiency. And it most commonly presents to men with sexual dysfunction, so erectile dysfunction or feeling tired all the time. And typically presenting to the GP, blood screens that are done would include things for like anemia, vitamin D deficiency, B12, thyroid function, etc., but not necessarily testosterone as part of that screen. And yet we know that 12%, so 1 in 6 men over 50 do have symptoms. And actually that raises to around 1 in 2 men with type 2 diabetes. And I'm not going to steal Mike's thunder in terms of the link with type 2 diabetes. And at some point, around 1 in 4 men over 30 will suffer low testosterone at some point in their lives. So we've already mentioned that symptoms of low testosterone affect a wide range of systems in the body and commonly present as sexual dysfunction, but also have physical, emotional, psychological and performance-related symptoms. So I'm just going to run through these in a little bit more detail, and then I'll be handing over to Mike. So sexual dysfunction is where testosterone is mostly associated. This can be low sexual desire, decrease in morning and nighttime erections, and erectile dysfunction. So not being able to maintain an erection. So commonly these will present, and for us in a pharmacy environment, that may be for people presenting, wanting some support, perhaps around something like Viagra, which we're very familiar with. From a physical point of view, a whole range of different symptoms that we tend to put down to aging. So a decrease in muscle mass, loss of physical strength, not responding in the gym to weight training, fatigue, low energy, lower bone density, less body hair, decreased testicular size, and man boobs, so gaining weight around the chest, and hot flushes, something we know women suffer from. And particularly things like sleep disturbance and just that general feeling of being tired all the time and fatigue, which can't be explained by anything in particular. We do see fine wrinkling of the skin, especially around the mouth in this particular area. From an emotional and psychological point of view, we've mentioned changes in cognition, just feeling like you can't focus, memory loss, feeling depressed, having less energy and motivation, and also being grumpy, irritable, linked again to this sleep disturbance, and generally not feeling very motivated. And I just want to sort of talk about this concept of performance, because this is often something that people will talk about. So yes, lower response to physical training, but also just feeling like you're not on it at work, not able to keep up, and this link to the loss of confidence. So I hope that's set the scene in terms of the context. But now Prof. Mike Baxter is going to talk in more detail around causes of low testosterone, how we might identify it as an issue, and also how we might treat it. So Mike, over to you.
Thank you. Debbie, can people see me? Am I on screen?
I'm not sure. There we go. Maybe, maybe not, Mike. I hope so.
No, it doesn't matter. You don't need to see me, but you can hear me. That's good. So, well, thank you very much for setting the scene. And actually, you set the scene very nicely, particularly with reference to, I guess, what's an urban myth, which is that women have menopause. That's related, as you rightly say, to sort of ovarian failure. And their estrogen levels, which accompany that ovarian failure, fall away. But up to relatively recently, it's been assumed that men don't experience that, and the idea of a male menopause is actually relatively new, still slightly controversial. And also is interesting in terms of the biochemistry and endocrinology that it purports to describe. And we'll discuss that in a bit more detail just a bit later on in the talk. This slide really is again prompted by Debbie, suggests and showing a whole range of things that can be related to testosterone deficiency. But the real purpose for showing you is not to go through any of this in particular detail, although I will reference type 2 diabetes as Debbie has invited me to do so, but really to emphasize that the identification of testosterone deficiency is not a diagnosis in its own right. And indeed, it's not actually even a symptom. We'll discuss symptoms in a second. It's an observation. And actually it prompts thoughts that require further investigation of what might be the underlying cause. So it is an observation, not a diagnosis. Now, I will a bit later in our discussion give us a little bit of more of a detail about how endocrinologists think when they're addressing this issue of testosterone deficiency, but actually it's as almost a sort of an example of the complexity of it. As Debbie says, there is an association with type 2 diabetes with testosterone deficiency, but no one really quite understands why. And that's because it's rather complex. And type 2 diabetes, as many of you will know, is associated with aging, and in the UK is mostly one of the most common driving factors is obesity and what's called an increase in insulin resistance, which means there is an increasing demand for insulin that the body simply can't cope with, and therefore you get this glycemic dysfunction that we know as diabetes. But what we also know is that the accumulation of adipose tissue has an adverse effect on testosterone level, and partly because, and we'll discuss it in a little bit more detail later on, is the adipose tissue can convert testosterone to estrogen. And what that obviously has a major influence in the balance of the hormone levels. And as the testosterone falls, it drives insulin resistance. So the problem with diabetes increases. So there is this sort of complex multi-directional interaction that link diabetes and testosterone deficiency. I have to admit, Debbie, I didn't really realise that a prevalence was as high as you quote, and it actually prompted me to go back to the literature. And you are quite right that there is about a 16% identification of true and easily defined testosterone deficiency, but then nearly a 30% incidence of relatively low testosterone levels. So the association you speak to is real. So again, just to go back and summarize, this slide is really meaning to emphasize that low testosterone is an observation and it's driven by something. And here is a very comprehensive list of what that might be. Next slide, please. So Debbie mentioned symptoms, and actually it's a list of symptoms that I think if we're all honest with ourselves, we'd write down many of those boxes we might tick. But it's quite good that this ADAM index tries to bring these together to create at least a working basis for how for the symptom complex that might be associated with testosterone deficiency. And I think it is very interesting that, and I was speaking to Debbie earlier in the day, that 3 of these questions, let me say that another way, you only need to answer 3 of the right questions positively, and this algorithm drives you towards considering testosterone deficiency. And they would be, and almost as emphasized by Debbie in her prelude to this, is decreased libido. And actually, in my experience as an endocrinologist, this is the most prominent symptom of testosterone deficiency. It's not being able to get an erection, is that you just don't care if you've got an erection or not. You just lose that drive that most men experience during their early lives towards an interest in sex. So that's the first. The second is the reduction in the strength of erection. And actually, I think that's quite a good way to think about it. It's not that you don't get them, it's just that they're not quite like they used to be. So a reduction in potency is another very, very prominent symptom. And then the third one, which might surprise you, is height loss. And this is because of the relationship between androgens and bone health. And as with women, when their estrogen level falls, the rate of bone reabsorption and the progression to osteoporosis increases. The same is true in men. And vertebral collapse and shrinkage is a prominent symptom that speaks to a testosterone deficiency. Many other things on this list I have great sympathy with, being slightly grumpy, not feeling that I was quite as good as I used to be, all of those things. But I do think that another one that has a prominence and an explanation is the lack of or the reduction in muscle mass and strength. And indeed, we know that as people age, they lose particularly lower back, buttock, and quadricep muscle mass. And that actually has a fancy name. It's called sarcopenia. And it explains why, as we get older, we get stiffer, we start to walk in a slightly different way, and we become less able. So that's a real physiological phenomena. And clearly it's something that we would wish to avoid, and probably underpins another observation that as we get older, our tendency to fall increases, and falls aren't very good for anyone, and they're particularly not very good as you get a bit older. So that is a very, very prominent symptom. So this is a list of things that make you think about whether or not there may be a testosterone issue. If you identify a testosterone issue, and we'll go on to in a minute to how we do that, then the next question is, why has that testosterone problem arisen? Is it part of this physiological decline that we now recognize, or is there an underlying pathophysiological process? Okay, go on to the next slide. So this slide, again, I don't want to dwell on the numbers too much, because because they do vary from laboratory to laboratory. But I think it does help us emphasize a couple of things. The first is that any blood test to assess testosterone should be done first thing in the morning. And this is because testosterone, like cortisol, which is a hormone that deals with stress and is related and influenced by our sleep and wake cycle. These hormones have a strong diurnal variation, and they're high in the morning and they're low in the evening. And so you can get false measurements by measuring testosterone later in the day and think it's lower than it actually is. And so making sure that all samples are taken at around 9 o'clock, seems to be the magic number, it is important. The second element of this is that testosterone alone is not really as helpful as you might think. It's a good indicator, but it's not a definitive marker of a problem. And one of the main reasons, or one of the main issues, is alluded to in the panel on this slide, which is that the measurement that's most commonly given is total testosterone. But we know in the blood that testosterone is bound to something called sex hormone binding globulin. And actually what we're really interested in, and the biologically active element of testosterone, is the free testosterone. So in fact, total testosterone is only interpretable when you know what the free testosterone is, or you know what the sex hormone binding globulin level is. Because you can imagine a scenario in which you've got relatively high testosterone, but enormously high sex hormone binding globulin, and your free hormone is therefore very low, even though your total testosterone is telling you that it's okay. And conversely, you could have quite low total testosterone, vanishingly low levels of sex hormone binding globulin, so all of it is free. So although you've got a low total testosterone, your active testosterone is completely okay. So knowing the free testosterone or the sex hormone binding globulin and estimating the androgen free index, that's the terminology we give to that particular measurement, is very important. There's also two other things that are quite important to measure, even at an early stage. And they are one of those relates to your gonadotrophic hormones. Now, this is the name that we give to the hormones that are produced by your pituitary gland and make your testis work. And there are two of them, LH and FSH. And LH drives your testosterone production, and FSH drives your sperm production. And we need to know what those hormones are in relation to your testosterone to make some sense of what's going on. And I'll illustrate that in a second on the next slide. And the other thing that's quite useful to know, and I've sort of already alluded to it in my description of the complexity of the biochemical interaction in type 2 diabetes, is it's sometimes nice to know what your estrogen level is, because you could have low, middling levels of testosterone, but very high estrogen levels, and clearly your balance then becomes out of kilter and creates its own problems. And estrogen, too high an estrogen, is a rare, but is a significant issue that needs further investigation. So saying we're going to measure your testosterone is right, but as always, it's slightly more complicated than just that single measurement of your testosterone. So the next slide, if I may, Debbie. So this is an idiot's guide, and that's not implying you're idiots, of course, but an idiot's guide to the sort of endocrinological issue of low testosterone. And basically, I think that we tend to think in relatively straight lines. And so it's either that your gonads, your balls, your testes aren't working, and that's called a primary problem, or it's at the other extreme that your brain isn't working and you're not producing enough of these gonadotrophic hormones, and we call this secondary hypergonadism, or it's a problem somewhere in between those two things. Now, primary hypergonadism, as I've said, it tends to be when your testes have failed, you've had testicular trauma, you may have been caught by the Secret Service and been electrocuted. I'm sure that's not the case, but that's what happens in all the films, isn't it? But they could have been removed because of cancer. There are obviously reasons in which your gonads stop working. And under those circumstances, and predictably from what I've told you about the biochemistry, what we would see would be very low testosterone levels, because you basically haven't got the mechanism to make testosterone. Your brain doesn't really know that, so it's shouting really hard at your balls to work better. And so you get very high levels of LH and FSH. And if we examine your testes, we would find that they were either absent, and believe me, sometimes even in adults, that's a finding that we have, or they are small and less functional than they might be. On one of Debbie's earlier slides, she mentioned genetics. There is a genetic syndrome that you might have heard about that's associated exactly with this, and that's called Klinefelter's syndrome, which is a genetic chromosomal disorder, but those patients present with exactly this picture. So at the other extreme of this is related to your pituitary gland and its ability to produce the gonadotrophic hormones to drive your testosterone production. And there are a variety of things that can lead to pituitary dysfunction, surgery again, a stroke, inflammation, sometimes cancer, but actually much more commonly that some of the other hormones that the pituitary produce are being overproduced, creating a problem for pituitary function. And the most common cause of secondary hypergonadism is a condition called hyperprolactinemia, where a hormone called prolactin is released at very high concentrations, and that inhibits the gonadotrophic hormone release. This is much more acutely diagnosed in women who often present with galactorrhea. Their breasts start making milk. In men, that doesn't happen, and the presenting symptom is often impotence or reduced libido. And because it's a bit of a further on in the process, tends to be a later diagnosis. Now, in this situation, as I've described, your LH and FSH are very low, your testosterone is low or very low, and one of the things that we would measure under those circumstances is your prolactin, which is often high. So those are the sort of two extreme elements to this. And then the next two lines, and I'm only going to really concentrate on the next two lines, are sort of formed fruits of what I've just described. So we recognize a condition called subclinical hypergonadism. And what that refers to is the biochemical observation of a low or low normal testosterone in the face of high gonadotrophic hormones. And what that's trying to describe is potentially a point in the progress towards primary hypergonadism, or a dysfunction of the testis that the body is trying to compensate for by shouting louder and giving a bigger signal for testosterone production. And that condition we know can benefit from testosterone therapy. And then we have the male menopause. Now, the female menopause is quite well documented, and most people would know what I'm about to say, which is that it's associated with very low estrogen because of ovarian failure, and very high gonadotrophic hormones because the brain is trying to compensate for the ovaries not working. Now, in the male menopause, it's completely the reverse situation. And what's described by this phrase of male menopause is that there is a gonadotrophic failure, and that's accompanied by testicular failure and a reduced level of testosterone. Now, what drives this functional gonadotrophic deficiency isn't well understood, but might be part of that aging process. And obviously, it is important to recognize this condition, but you only can diagnose it if you are measuring both the testosterone and the gonadotrophic hormone levels. The last two I can discuss if you have questions about them, but for the moment I'm not going to explore those in the interest of time. So that's a sort of endocrinologist idiot's guide to what some of these hormones mean and how they tell us the problem that we're actually looking at. So if we move on to the next slide, if we may. So what can we do about this? Well, obviously, if there is a underlying pathological or pathophysiological profile, let's say you have a pituitary tumor, then you need to be treated. If for some reason your testes aren't working at all, then you need treatment. But if you lie in the middle, the so-called subclinical hypogonadism, or the early stages of the male menopause, you can see, as I've described them, that they're sort of subtle dysfunctions, and we may be able to do some things to make that better. And this is a list that you would see for most medical conditions, I guess, and healthy living. Nothing so clever about this, but actually there are quite important bits that speak to the sort of underlying mechanism. So weight loss, and particularly the loss of visceral fat, is extremely important. And I've already really told you why that is. And that is because testosterone is metabolized by fat. Everybody thinks fat doesn't do anything, but it's a very metabolically active tissue, in fact. And it converts testosterone, which technically is a C19 steroid, to estrogen, which is a C17 steroid with what's called an aromatization of the A ring. So it transforms the steroid hormone testosterone to the steroid hormone estrogen. And clearly that isn't good news. And if you can reduce the amount of fat, and that has a very beneficial effect on testosterone levels and particularly estrogen levels. Exercise is also quite important, but again, it's slightly complicated. What's clear is that extreme endurance exercise is actually bad for your testosterone levels. And this is perhaps exemplified by women, and women marathon runners, particularly ultra endurance athletes, are all amenorrheic. They don't have periods. And the reason for that is that exercise drives up your prolactin level. And as I've already alluded to, prolactin inhibits your gonadotrophins. And in women, this is manifest by a reduction in estrogen and actually periods stopping. But in men, it's a bit more subtle, but there is really quite good evidence that it does lower your testosterone levels. And so that's bad. But actually high intensity training and a stress training, weight training, anaerobic training is actually very good for your testosterone levels. And so that's why on this slide, it specifically says high intensity, and it could stroke weight bearing exercise. Reducing stress is good, partly because it reduces the influence of the stress hormone cortisol, which I've mentioned earlier in the talk. And sleep, I guess you can see if there is this diurnal variation and this requirement for a diurnal cycle of testosterone, that the better quality of sleep and allowing your testosterone to rise, it would be of benefit. So all of those things that are slightly trite, aren't they? And they're trotted out for most things. There is actually, for testosterone deficiency, quite a lot of good mechanistic evidence and a sensible explanation that these interventions offer. Next slide, please, Debbie, if I may. So I think this is probably our last slide, you'll be pleased to hear. So I've mentioned that although those interventions can be helpful, particularly in the nuanced dysfunction in testosterone, that actually in more extreme cases, then actually testosterone supplements is the right way forward. Now, one of the reasons I'm an endocrinologist is that it's sort of magic medicine. If you've got a hormone deficiency and we can give you your hormone, we can make you normal. We can bring you back to being the person that you want to be and should be. And so, and testosterone is an endocrine problem where that is clearly demonstrable, that if you have low testosterone because you've got no pituitary or your testes aren't working or it's just stopped working, then giving you testosterone back is the obvious way to bring you back to normal. And testosterone can be administered in a number of different ways. We used to use testosterone tablets, but we've stopped using them for a number of reasons. Firstly, you need to take multiple tablets in the day. And secondly, there is a first pass effect, i.e. the drug is absorbed by the liver, which makes it a very inefficient way to give you testosterone. And there were concerns about increased levels of testosterone in the liver creating problems. So we simply don't use that anymore. What's now the most popular means of giving testosterone is with gels or creams that are applied to the skin, and there is a transdermal absorption. And actually, it's a very effective way of giving testosterone almost directly into the systemic blood system and bypassing this sort of liver effect. It used to be that came in sachets, and patients used to complain that, you know, because you have to apply it every day, usually after a shower. One of the usual questions is, do I need to apply it to my testis or my penis? The answer clearly is no. You just need to apply it to any bit of skin that you can get to. But people used to complain that they used to accumulate masses of these aluminium foil wrappers that they needed to dispose of. But now gels come as a very nice pump dispenser, like soap dispenser. And that's the most popular prescription for testosterone in my practice. People like those dispensers, and they can apply 1 or 2 pumps to their skin, and they do it as part of their routine. The other way that we can give it, and some people don't like having to do something every day, and the way that some of the sports people use steroids, which of course is a completely different discussion, but one I'm very happy to have, that the testosterone is given by intramuscular injection, usually in a suspension of oil. Mostly it's given as a 3-monthly injection. Well, at least that's the manufacturer's suggested dosing frequency. And at those time points, they usually involves large depots of this oil and testosterone, up to 4 mils by an intramuscular injection, which some people find really quite uncomfortable. Also, and I've sort of given the game away slightly, in my hands, it never lasts as long as 12 weeks. So you end up giving it 6 to 8 weekly, which becomes something of an imposition, and people don't, some people don't like that. Interestingly, some of the guys that do this all the time are experimenting with something called microdosing, that if you have any interest in cannabis taking, you might recognize that that's also applied in that particular area, using cannabis medicinally. And testosterone microdosing is essentially giving a very small dose of testosterone on a weekly basis. and to give a higher, more stable therapeutic level, but also avoiding the requirement for less frequent but more uncomfortable large injections. So that's something that people are experimenting with. As Debbie has alluded to on this slide, implants and that are used in ladies are not licensed for use in men, although some clinics may use them off license, but basically they're not licensed. Now, on this slide, there is a very important point, which is hormones sometimes get the rep of being very rapid acting, don't they? If you take too much thyroxine, you feel like you've drunk a double espresso, and you're running around the room, and people have that sort of, and insulin works pretty instantaneously, etc., etc. But steroid hormones work in a very different way physiologically, and they bind to intracellular receptors and are transported to the nucleus of the cells, where they influence gene expression. And so, as you might have already guessed from that description, these effects sometimes take a very long time to take effect, because they influence protein, hormone, enzyme production. So this is suggesting 6 months minimum and up to a year to fully assess therapeutic effectiveness. And I don't think that is unreasonable. The other thing that's perhaps is not here that should be, and maybe one of the concerns that potential patients express, is there a downside of testosterone therapy? And actually what we always endeavor to do is to replace to a physiological optimum that addresses the patient's symptoms. It's that sort of balance. What we're not after doing is making you Arnold Schwarzenegger and giving you dirty, great big doses of testosterone, raising them to supraphysiological levels, and creating a sort of pathological situation. So monitoring of testosterone and adjustment of dose, individualization of dose to give optimum levels, is also a very important element of testosterone therapy. I think that was my last slide, Debbie, and I think I might have covered things. So
yeah, absolutely, Mike, thank you. And I'm going to sort of bring this to a close with sort of the benefits and a summary. But before we move on, I just want to sort of link particularly what we've talked about, type 2 diabetes, and my understanding that there have been some studies done which are showing that for men that have pre-diabetes, there is some evidence now that having testosterone therapy can stop that progressing fully into diabetes. And I just wondered if you had anything to talk about these sort of link with the comorbidities and the benefits of actually going on testosterone therapy for those that are perhaps at risk of, as we know, diabetes significantly increases cardiovascular risk, for example.
No, and sorry, I did attempt to make that explanation, but perhaps I didn't, because it is quite complicated. So in the progression from pre-diabetes to diabetes, the first step is, for most people, not everybody, but for most people, and driven by obesity or weight gain, is this so-called increased in insulin resistance. And what that effectively means is that peripheral tissues like fat tissue, like muscle tissue, like liver tissue, becomes less sensitive, less responsive to insulin. And so the body has to compensate by increasing your insulin levels. And while you do that, you maintain normoglycemia, or, well, initially you do maintain it, but very slowly it might drift away as your ability to produce insulin to counteract this insulin resistance becomes more and more compromised. Now, clearly, there are a number of interventions at that point that might be helpful and to reduce insulin resistance. the one that everyone, of course, is talking about is weight loss. And if you can lose weight for a whole variety of complicated reasons, it can influence your risk of or your progression towards diabetes. But you are quite right that in patients in whom there is a low or suboptimal level of testosterone, that's exaggerating this cycle of increasing insulin resistance. And some people have proffered and use more aggressively than others testosterone replacement as a mechanism for reducing insulin resistance. So I think what I would say is it probably isn't the first line intervention, because weight loss clearly is. But in somebody who was exhibiting symptoms that we've spent some time discussing, who are demonstrably low testosterone levels, it would be more than sensible to discuss the potential for giving them some testosterone supplementation to increase their mass, to reduce their insulin resistance, and to help them. So yes, it is one of the tools and one of the interventions, but it probably wouldn't be the first one you pick off the shelf.
No, absolutely. Thank you. And throughout your presentation, which was fantastic, thank you, Mike, I'm reminded of the parallels with women and the impact of testosterone replacement, and also the need to monitor and keep within therapeutic normal levels. And so, yeah, we're more similar than we might think.
Oh, yeah, absolutely.
So in terms
as you know, I mean, that's not the purpose of this discussion, and this has been centered on men's health, which I think is really important, because men don't talk about their health so much, and we must encourage them. But and I know that you are also an advocate. Women also have testosterone, and actually most of their libido, and actually all of the sort of tendency for pubic hair and its distribution, is governed by testosterone in women. And part of HRT, which had focused historically on estrogen replacement, some of the subtleties are actually to use testosterone as well to help women, particularly around some of the sort of the libido and muscle issues that we've described for men.
Absolutely. And you know, certainly from a brain fog and memory perspective as well, it can really help. So just in terms of summarizing and bringing together the benefits of testosterone replacement, you can see them there, I hope, on your screen. We started this with the symptoms of low testosterone, and clearly replacing testosterone where it's indicated has benefits in terms of improving those sexual dysfunction and physiological and psychological problems that we talked about earlier. And then in terms of just pulling this all together before we go to any questions that you might have, this should say low testosterone is more common than we might think. We saw that in terms of the prevalence data. I think for us as healthcare professionals, and certainly in that sort of first screening, that sort of health check, MOT type approach, we should be considering the measures that Mike's talked about this evening: testosterone, sex hormone binding globulin, luteinizing hormone, FSH, as part of a measure of a number of different things, which would include things like HbA1c to see how glycemic control is going forward, and other issues as well. And that includes things like PSA and blood count and a whole host of different things. So it's important to recognize that those symptoms could be caused by a number of different things, but that we include the testosterone profile, the hormone profile, when we're screening our men, and that any of those symptoms are worth exploring in a consultation, and not just to be put down to a time of life or stresses and strains that are going on at work or at home. It's an important time to take stock and focus on health and well-being. We've got one chance at this, and nobody else is going to do it for us in terms of the healthy interventions that we can make to keep ourselves not just alive, but alive and well. So it's important as well to mention that testosterone isn't a panacea for all health issues, and that includes for women and men, but it can make a significant difference for those men who need it. And so we encourage all men and women to check in on their health and find out what you can do to add years to life and life to years. So I'm going to stop the sort of presentation aspect of this evening there, and just to say a huge thank you to Mike. We're just going to have a look in the chat now to see what questions might have come up. So this is your opportunity to pop some questions in there. There's also
there are two, Debbie.
Yeah, okay, go for it.
So this one's labelled law, and it's a slightly legal question, but I'm guessing that's somebody's name. So I'm sorry, I don't know your first name. That's just there. So it says, do I need a prescription from my GP for a Testogel? So the answer is, it is a prescription medication in the UK presently. Like most things, you can source them outside that, but our recommendations would always be to have somebody looking after you, a doctor or someone who can prescribe this legally for you. And actually, most of the NHS doctors are more than happy to make the prescription once it's been established that it would be helpful. So, but the direct answer is yes, you do need a prescription. And then Mike Murphy asks a really great question, and thank you for your compliment. That's very well received. Thank you. And asked a question about alcohol consumption and aromatization and the sort of testosterone and estrogen balance. And actually, I'm not sure I know the answer to that in terms of moderate alcohol intake. We do know that it does have an effect on oxidative status, and because alcohol is a substrate that's metabolized. But I don't think for normal drinking that this would be a major consideration. However, in people with alcoholic liver disease, the overproduction on the aromatization because of central weight and the liver dysfunction, established liver disease is a hyperestrogenemic state. And so the answer is yes, and that's why gynecomastia, ascites, fluid retention, all of those things that you think about being associated with chronic liver disease occur, and it's because of this hormone imbalance. So the answer is yes. In extreme circumstances, there's clearly an explanation.
Lovely, thank you, Mike. And another question that's coming from Law: can I use testosterone gel alongside the likes of Viagra?
So we haven't. So the answer is yes. And we haven't spent much time unpicking this difference between libido and erectile capability, and I think you've got a flavour of my thoughts about this. It's testosterone's predominant effect is on libido, and it does have some supportive effect in terms of erectile capability, and lots of patients, when they take testosterone, regain their libido, and because they've regained their libido and their confidence, etc., their erections improve. But it's not always a really good treatment for erections. And it's a question that I ask my patients when they come to see me. I ask them about their libido, and if they say, do you know what, I couldn't give a monkeys, but my wife's asked me to come, or my girlfriend's asked me to come because I'm just not interested, and that's the issue, then I'm very optimistic that testosterone is going to make a big difference to this patient. If someone comes to me and says, I'm so frustrated because I really, really, really want to have, sex, but I just can't get an erection, then I'm more nervous that actually this isn't going to transpire to be entirely sortable just by testosterone. And under those circumstances, then a combination of testosterone, if it's required, but Viagra, because that's mechanistically a very powerful drug for erections, is perfectly sensible. And I'll give you a little anecdote that I always remember one of my professors telling me when I was a student, which was the idea that eunuchs didn't have sex with the ladies in the harem was completely misplaced, because the eunuchs were usually adults when their testes were cut away, and their androgen programming had already occurred. So actually they were still quite capable of having sex. They just had relatively low libido, and of course they were infertile, so they couldn't make the ladies of the harem pregnant. But the idea that they didn't have sex with them was probably completely fanciful, but just for your amusement.
Thank you, Mike. I've got another question here, which thank you, Jane, is do we test here at Remedy Health for the profile that Mike suggested? The answer is absolutely, alongside pretty much anything else you'd want to get tested for. And is there someone who can interpret and prescribe? Yes. And the caveat being that we prescribe here HRT for women, including testosterone. We also supply it as a private pharmacy. But for men, we would refer to Prof. Baxter, another specialist, or to a GP, depending on the desire of the individual. So I hope that answers your question there. I've got another question for you, Mike. If one has compensatory primary hypergonadism with total testosterone 13, is a very specific question. Is it likely the NHS would typically adopt a wait and see policy until you test below 12?
So just so I'm clear, so you're talking about subclinical hypergonadism, are we? So low normal testosterone but slightly elevated gonadotrophic hormones. Is that the description?
Well, I've got compensatory primary hypogonadism with total testosterone of 13.
So I think that's what the question means, compensated for. So so this is interesting, and the analogy that I'll draw for you, because the answer is it slightly depends on who you're talking to. So the analogy for this is subclinical hypothyroidism, which is a much more common problem. And we see in endocrine clinics all of the time people being referred with low T4s and TSHs that are elevated or just elevated outside the normal range. And the response to that from the general GP community is split, let's say, for the sake of argument, 50-50. There'll be a group of people that say, this is not abnormal, the T4 is still in the normal range, I'm not going to treat until the thyroid level is outside the normal range. And there'll be a group of people that say, well, I understand the natural time course to development of hypothyroidism. What happens first is your TSH goes up, your T4 is laboring for much longer, but actually you're not normal because your brain thinks you need more thyroxine and it's trying to find it. And therefore we should treat you. And there are some ways that you can try to objectify that, but essentially they say you should be treated based on your symptoms and the biochemistry and making it right. And that story, I think, is replicated in compensated hypergonadism, although I think the people that wouldn't treat are more like 80% than the 50-50 split, partly because it's not recognized, so people don't, it hasn't got this label generally that makes people feel confident because it's a condition that I can name. And secondly, they just do not, they don't really understand the multitude of benefits that you might gain from actually simply exposing your testosterone, exposing you to testosterone and putting it up. And although I deferred from a conversation related to the levels of testosterone, again, a bit like thyroid, if you look at them, the normal range is 9 to about 28. And patients can legitimately ask the question, well, where should I be? I'm 12, but should I be 22? And there isn't an answer, is there? There isn't an answer. But I think, I'm in the camp, as you might expect, if your gonadotrophic hormones are high, your brain wants more testosterone. And I think it's a perfectly reasonable thing to at least have a therapeutic trial, a pragmatic trial of therapy, where we give some testosterone and see what happens. But I think out there, that's less of an adopted practice.
Brilliant, Mike. Well, I think that's all we've got time for. It's been incredibly interesting and fascinating, and a huge thank you. And thank you to everybody attending this evening. We will send out a recording to you all for coming along. And if you want to speak to us at Remedy Health at all about any health concern, then please do give us a call. You can pop to our website, remedyhealth.co, Remedy with an I, and find out how to contact us. And we're always happy to have a chat, as is Mike through his practice. So thank you so much, everybody. Thank you, Mike, and have a fantastic evening. Thank you.
It was a great pleasure. Thank you for listening. Thank you.
Thank you.